Hello, everyone. Welcome to the BrainX Community Live February 2020 edition. And we're very excited to share this via Zoom as we have gone to online mechanism for having these community sessions. We have two very exciting speakers for this event. Dr.Cywinski, he's an anesthesiologist. He's also the medical director for liver transplant service and the anesthesiology institute at Cleveland Clinic. He's the quality officer of general anesthesiology, and he's going to talk about clinical variation management and quality improvement using machine learning and AI. And we have Dr.Habboub who will follow that talk, explaining to us what reinforcement learning is and opportunities for application of that in healthcare. So to talk a little bit again about BrainX community, it's a group of experts and novices who have joined together to form this 2,000 plus member international community. And we have been sharing a lot of scientific literature in the space of machine learning in healthcare. And the idea being that we all want to collaborate together to expand our learning horizons, to possibly work together, do certain projects together, and learn from each other. There are two web pages, which is brainxai.org or simply brainxcommunity.com. Both of them link to the same web area. And then the active community resides on the LinkedIn group with the name of BrainX Community. And we have been having these monthly live sessions, excited about going online with this. If you go onto the BrainX Community webpage, three areas. One is connect, the other one is data, and last is learn. The connect, which is now online, is the area where we put in material from the monthly sessions that we hold. LinkedIn is the active community where we share a lot of scientific material and information about our work and possible meetings. And then the learn section, which has a list of curated articles, which are handpicked and annotated for different specialties so that you can review those and can be shared amongst various different members. We all need access to data. So the data section has a repository, which is now the largest repository of all open source data sets, directly links to those data sets, and they're all from different specialties. So it's a one-stop shop for access to data. Last year, we launched the Europe chapter for BrainX community, and we are hoping to have more sessions this year from Europe. One of the new areas we had launched recently was the journals section, where all the journals which belong to medical specialty and are focused on machine learning or artificial intelligence are listed over there so that you can directly go from this area to those journals. And the meetings section lists meetings which are focused on machine learning in healthcare. You can click on them, go directly to these meetings, can register for them, and attend those. Once again, here are the different ways that you can connect with us. And with that, I'm going to invite Dr. Cywinski, asking him this question first about what made him interested in application of machine learning in healthcare.
Hello, can you hear me?
Yes.
All right. Hi, everybody. So I think that the main driver for my interest with AI and machine learning was my clinical practice, because I realized that I spent too much time really trying to retrieve or input information into the electronic systems. And actually, it's incredibly difficult to retrieve this information and use it to help patient. And this time which is spent on trying to find the right information and putting the information into electronic records actually takes you away from the patient. And also we know that all these hurdles we have to go through with the electronic medical records cause a lot of burnout and divert us from providing clinical expertise to our patients. So I was kind of trying to see how companies like Google, Facebook, Netflix, or you can name from outside of the healthcare space, many of those companies, how they can leverage the enormous amount of data they collect every day to propel the business. And that's pretty much is what I think needs to happen in healthcare. Even though we have enormous amount of data, we still at the very infancy of using this data in a meaningful way, which helps us as a clinical providers and also helps our patients. So that was main reason I got interested in AI and machine learning.
That's great, Jacek. So let's go ahead with your presentation. Thank you.
All right, so what I would like to do is to talk about clinical variation management. And I have full disclosure, this presentation is very non-technical. I'm not gonna talk about any details of machine learning or artificial intelligence. It was just more to build the framework, or how should we approach the AI and how AI can help us with what we do poorly actually in the healthcare. And I want to start with, I'm just gonna figure out how to advance my slide. With this simple equation. Right now in healthcare, everything is about the value. So we moved from volume-based services to value-based services. So we are expected to provide value to our consumers, which are patients and payers. And the value can be defined as outcomes divided by cost. And of course, in ideal state, would provide the best possible outcomes at zero cost, but that's not really doable. So we have to balance how we can calibrate acceptable outcomes and provide them at acceptable cost. So what really stands between us providing the value and our patients is this gap in a quality of care we deliver. And that's really nothing new. It was discovered, and in the seminal paper put out by Institute of Medicine in 2001. And one of the biggest problem in a healthcare which drives down the quality is variance in healthcare practices across the whole spectrum of the services we provide. So in other words, the same patient with the same clinical picture, the clinic or disease for which we have well-known established way of treatment, can get 10 different treatments depending on where they go. And that leads to medical errors, omissions, and obviously we're all aware that medical errors are thought to be the third leading cause of death in the United States. But beyond that, and perhaps more patients are affected by not getting the evidence-based treatment, inefficient therapy, being exposed to unnecessary tests, and other inefficiency, which drive the cost of the healthcare in this country, and I would guess anywhere around the world. And also, it provides poor quality service. But the root cause of this is related probably to not having the right information at the right time. And ERAS protocols, which were developed at the beginning of 2000, were supposed to address this problem of not having the right information and not being consistent in the treatment we provide in a surgical patient. So ERA stands for Enhanced Recovery After Surgery. And it was supposed to be a data and evidence-driven approach to the problem we have at hand. It's supposed to identify the issue we have with our process and identify them in a way that we can measure the problem, develop and adopt best practices, and that should be evidence-based, identify interventions which have the highest impact on the outcomes, so that would involve cost and benefit analysis, and finally implement those interventions or recommendations and set measurable milestones of success, and just repeat this process over and over again until we fine-tune the process. And while doing this, we would monitor compliance and modify it as needed. So after that, in early 2000, there was a lot of guidelines popping up addressing the ERAS protocols for a variety of different surgical procedures. So essentially, any surgical procedure right now has some sort of guidelines of enhanced recovery. However, the biggest problem what we faced with those ERAS protocols was the implementation. So even though we knew exactly what needed to be done, there was still poor compliance, probably not enough good evidence supporting the benefit of individual components of the ERAS protocols. There were differences which precluded use of the same protocol in different populations and different hospitals. And perhaps one factor which we don't really understand what it entails was human factor. That's, for some reasons, people would not follow the protocols. And this study, which evaluated compliance with the well-established ERAS protocols in a hospital system, showed how abysmal is our performance and adherence to the ERAS protocols. Only 21% of the patients who were eligible for ERAS protocols actually had all required intervention required by ERAS implemented. So what can we do about it? Well, I think that our great opportunity is to leverage the information what we have in electronic health record. And many still argue whether EHR can be called big data, but for sure it contains a lot of information which right now are not really used very wisely. So really we should think about this concept of learning health system, where we use the data to come up with some recommendation, with some pathways. And while we collect more data, these pathways get fine-tuned, and it's essentially perpetual cycle which goes through the data collection, data analytics, and then development of the pathways which improve the patient's outcome. So we did this little project on our surgical population to see how we doing treating the colorectal patients who supposed to be following ERAS protocols. So we partnered with the company called IASD, and they have software which is called Clinical Variation Management, which helps to understand the data, the clinical data, and also with supervised and unsupervised machine learning can point out some differences in the pathways the patient take during the clinical journey. So, as I said, we looked at close to 1,800 patients who were all undergoing colorectal surgery. To the best of our knowledge, all patients were treated according to ERAS protocol developed by ERAS Society. And we were just wondering how this software, how the data can enlighten us about the patient management. So the promise of this application was that it will help us to discover patterns in a clinical data set, that hopefully it will help us to identify the best care practices, and will help us to build the pathways which can be added to our current pathways. And also it will provide the tools to continuously analyze the data and modify pathways over the time. So our approach was 5-step. First, we collected pretty much every data we can put our hands on about those 1,800 patients. Then the software help us to group the patient in supervised and unsupervised manner, so we can identify the differences and subtle nuances in a population. And based on this analytics, we identified desired pathways, patients who had the best outcomes. Then we went through the clinical appraisal, making sure that the patterns we identified purely in a data made clinical sense. And then we explored the possibility of using the software to provide continuous in near real-time prognostication of the clinical risk and generating compliance reports. So in unsupervised analysis, to our surprise, the software identified 9 very distinctive groups. And just looking at these groups help us to understand how different patients take different trajectory through the clinical process. So then we ask the question, what is the characteristics of the patients who have favorable outcome? And we define favorable outcome as low direct variable cost, low length of stay, and the low 30-day readmission. And comparing those groups with the favorable outcome and those with inferior outcome help us to uncover the differences in a clinical management. And after identifying these differences, we validated with the experts in the field about whether those differences are clinically valid. So this is an example of the way the software analyzes and presents data. So in this particular example, we have topographical data representation of duration of the length of hospital stay. So you can see that the software very quickly clusters the patient with the best outcome in a certain positions of this graph. And also this graph represents the similarity between each individual patient. So then once we identify the groups or the subgroups of this colorectal cohort, we were able to look at the details of each groups and how interventions, clinical interventions provided during the hospital stay compared to consensus or our desired clinical pathway. So in this particular example, you can see that we identified the group of 694 patients which had similar clinical characteristics. And then software allowed us to break it down to individual patients. And the horizontal line here is essentially represents the time, and each vertical line represents the clinical interventions. And those up on the top, those vertical lines represent individual clinical interventions, which are supposed to be part of the clinical pathway. And you can see that even with the groups which seemingly were very uniform, each individual patients received different clinical interventions, and some of them never really got intervention which were meant to be given according to the clinical pathways. And this analysis allowed us to identify the interventions or the elements of the ERAS protocols which were associated with either favorable or unfavorable outcomes. So based on that, we're able to isolate elements which actually potentially drove the good outcomes. So for instance, favorable length of stay and cost was associated with use of ketorolac, restricted fluid management, and surgery for cancer. Readmissions and longer hospital stay was associated with liberal fluid management and diabetes. So when you look at those elements, they are not particularly new. I mean, we didn't have to go through this exercise to learn about this, but also think about this way, that it showed that this software actually is able to pick up the clinically relevant and actually valid interventions which drive favorable outcome. So based on this experience, we learned that machine learning can help us to build the pathways, and that can help us to adjust the pathways to individual patient makeup. So we don't try to squeeze everybody into the same pathway. We rather try to tailor the pathway based on patient clinical makeup. And that can be done very much in an automated way. It's purely data driven, and it can save a lot of time for the clinicians, because it truly uncovers the patterns and the trajectories within the data. So instead of trying to push every patient through the same pathway, which may or may not work, and certainly for a variety of reasons, and what we know from different studies, it doesn't work. We try to tailor the ERAS protocol to individual patients, and hopefully by doing that, we can achieve desired outcomes. Also, the software or the machine learning allows us to look closer into the population we're dealing with. It can help us predict the risk trajectories. It can help us identify the drivers of the risk and inform us about most efficient ways or interventions for delivering best outcomes. And really the beauty of this approach is that it continuously improves itself as it collects more data. So what did we learn from this exercise? Well, we learned that what seemed to be pretty uniform group of patients actually in reality was not. There were 9 distinctive groups. we were able to very quickly select the best performing groups. And we also were able to identify the high impact interventions, which after clinical validation were drivers of the better outcome. We were able to identify variability within the treatment patients received very easily and very quickly. And also we learned that clinical prognostication can be fine-tuned along with the patient care. And also what was interesting, we found that with this tool, we can provide near real-time compliance feedback to the providers. And by doing that, potentially we can get the patient back on a track to follow the ERAS protocols. And the reason I'm bringing this up is because, we know that a lot of what we do is in a healthcare is not really discovering new knowledge. It is more of trying to consistently apply what we already know. And this is another example how difficult it is to be consistent with the care we provide. So in this study, the authors look at very simple abdominal surgical procedures, healthy patients, and they look at the amount of fluids which were administered for the patient. So as you can see, it was all over the place. And the biggest driver of this variability was individual providers. So clearly, variation management is a very important tool to provide consistency to the care we deliver. So when we can think about the way to think about the variation management is that based on the data and real-time analytics, we can provide guidance to the providers, we can assure compliance, and also introduce accountability. So this is my last slide, and I think that what I was talking about in context of ERAS protocols is just like a small scale problem in a way that it just affects patients who are undergoing surgical procedure. However, the problem with variation in a clinical approach, a clinical treatment, is not unique to the surgical setting. Actually, it's probably common in any specialty, any field of the medicine. And by helping to reduce variation in a clinical care, we can perhaps drive the quality and deliver better value to our customers. The biggest problem, though, which I have to fully disclose, is how to implement those systems, because we know that we get very easily fatigued with best practice alerts and constant feedback, those automated reminders. So that needs to be figured out, how to build the clinical variation management system into our workflow and make it sort of naturally and organically fit into our clinical practice. Thank you.
Thank you, Jacek. That was a great talk, and trying to explain how machine learning can help us in measuring clinical variation and learn from that, and maybe even learn from identifying, which are best practices and which practices are the ones that are not really helping with outcome. I think Dr. Guha has a question, but we'll hold the questions till the end. And in the meantime, I'm going to request Dr.Habboub, who is a neurosurgery fellow, very well trained in machine learning and AI, to talk to us about what motivated him to explore this field of machine learning or AI in healthcare, and then help us understand the applications of reinforcement learning in healthcare.
Thanks, Dr. Mather. Probably ask Dr. Cywinski, help me if I can share my screen. Perfect.
Here we go.
All right. So, well, thank you again for asking me to talk about this. This topic has been like, I've been working on reinforcement learning for quite some time now. And I was recently in a meeting, and the person who I was talking to, he told me, you know, God is the answer, but what's the question? And it's kind of, that's my track in reinforcement learning, where it's fascinating, but sometimes you need to figure out what's the question even to ask in reinforcement learning. And it's very, it is very challenging, and it comes from kind of a different background, which we'll go into, and integrating that in healthcare is definitely a challenge. We're having difficulty with the other method, machine learning, but this is even a more challenge. So it kind of went back, goes all the way back where, you know, all that vibe came from AlphaGo and the game of Go. And kind of the complexity of this came, you know, from chess and game of Go, where you have a lot of search space, meaning like you can at any given time do a ridiculous amount of or a move, like any sort of move, it can lead to a different outcome. And to figure out what's the best move at that given point of time to win is remarkably complex from search space. And the usual algorithm used to be in the past, or brute force, or like the old depth first or breadth first search algorithms. Doesn't work when it's the search space is that wide. And that kind of where, you know, where AlphaGo came with providing another algorithm where it not really goes through this search algorithm per se, but rather more a trial and error approach. And subsequent to this, or actually even prior to that, there's, you know, Google kind of published DeepMind, published several articles talking about how you can utilize the same algorithm to solve all sort of games. And these games are pretty complex, and it range from simple games where you can kind of Atari type of games to more fancy like Doom or something like this, where you know, it's pretty complex to solve these games. And these algorithms reach a point where they kind of unbeatable, basically, the algorithm. And all I needed is provide some basic information where at any given point where the age in the player is, and what weapon it provided, and so on, and provided a pretty fascinating result. And subsequently, you know, AlphaGo and AlphaGo Zero came in with this trial and error approach. And like when I was reading all these articles, this is fascinating. This is like the way to solve healthcare, correct? You just try and error, and it should solve any problem. But then the question I had is, what problem I should solve, and how can I define that problem? And it seemed like the solution is there, but like, how can you get that problem? And so just kind of going a step back, kind of talk a little bit about reinforcement learning. So reinforcement learning, the idea is, well, you have some sort of environment and some sort of agent, and the agent kind of interacts with the environment by performing some sort of action. And let's say if you're in the game, maybe moving right or left, and then the environment will provide some sort of feedback. And the feedback in two components. One is some information that the agent can use, meaning like the location of the agent, or maybe their life, or And then some sort of another variable is the reward, which is how good is the agent is doing by performing that action. And through this reasonable and it's not very complex interaction, you can kind of see. So one of the I guess work, if you want to call it, that I've done in the past when I was doing that reinforcement learning 9th degree at Udacity, and it was like training simple stuff where you have this simulated environment, and you're supposed to be collecting the yellow, not the blue bananas here, and you only need to provide the images to the algorithm and the actions, just kind of right to left here, and it will figure it out, not even telling the algorithm that you need to collect the yellow bananas, but just providing a score with time. It can even go more complex where you can kind of, another project where we kind of two agents interacting together and both kind of collecting the reward at the same time, or even you can do it in a competitive way. But this is all great, and to me, okay, well, I have some sort of skill on how the solution, but again, like, what's the problem? And then, I realized that, reinforcement learning has been used significantly in robotics. Well, maybe I should, invest my time there. And through simulation, you can kind of get some sort of, I guess, a baseline to see if a robot can perform some action. So we done some work on creating a simulated environment from a robot. And the initial task, I thought, well, maybe a complex task for a robot to do is find a ball in space and try to reach for it. And so the way you do it is basically you need to create that environment we talked about. And that environment I create on a platform called Unity, which is heavily used in the gaming industry. So you create that environment, and then through reinforcement learning methods, you can teach that robotic arm how to move each joint to reach that ball. And this is pretty complex when you have a random ball moving like in a large space. And you can see with time, the algorithm kind of figure it out. So you see if the top figure, it's learning the reward function. So with time, it keeps learning how to reach for that ball better and better. And you can see it like in action here, where you can, in the top video, where it's kind of clueless, and the bottom one is kind of able to reach that ball in more reasonable time with this amount of degree of freedom and number of joints. And this is after obviously long several days of training. So great, how can you use this? I mean, of course, I don't have robotic arm in my access to, but maybe this has potential. I still struggled with what can we do with this. And then recently there's another publication kind of briefly mentioned at the end, like how you can use in sepsis management and even fluid management and so on. And kind of the idea is, well, if you can define the action space, which is here how much fluid you want to give, or maybe pressors, or and you can look at outcome, mortality, or so on. You can maybe use that reinforcement learning algorithm to kind of automate the fluid administration or pressure administration for that patient. And the challenge, though, is the idea of transition. So the way our reinforcement learning works is the environment will have to provide some feedback to the agent about how he's doing with the action he requested. So meaning if the agent, which is the algorithm, decided that I want to increase the fluid rate to this number, and then the environment should provide back, well, in the next maybe 10 minutes, you should the predicted value of let's say of the vital, the blood pressure, for example, should be within that range. But even that number we don't know. So how do you kind of figure that out and integrate it into an algorithm that would make sense? And a lot of the initial work of reinforcement learning was more centered about what we call a model-free approach, which is basically a trial and error approach where the algorithm can go and kind of play around, see how things work, and then get some rewards out of this. And then based on that, it will adjust and select different routes. That's what we call explore, or select continue with that the same route because it seemed like good, was what we call exploit. And that's great, but I mean, you can't really apply that in patient care. We can't just tell the model, try it and see how the patient, and then learn from that. It's not ethical and it's not making sense anyway. And so the different paths you can do this model-based approach or off-policy approach, what we call it. And the idea is, well, maybe we can get some data from somewhere and learn that transitional function or matrix, what we call, and then based on that, given these information on the patient and given that action, we predict that patient will be in that position and the X amount of time in the future. And well, it was also great, but how can you implement it? So I mean, this is more doable, I think, in the world of reinforcement learning and healthcare and decision making. But how can you make it? And the transition function goes as follows: given you want to kind of look at the probability of being in this state in the future, given the previous state, what we call T-1 here, in the time minus one, the previous time, and given the action you selected. So that's kind of what we call the transitional function. And if you can figure it out, I think you can significantly kind of get closer to where you need to be. And sorry, I know it's probably too much code here, but my point here is you can, if somebody wants, obviously define the environment, even though it will not be easy. And the way it would be is figure out what that transitional function is. And the way to do it, unfortunately, given the limited knowledge we have about how the patient, let's say in the sepsis ward, will be given these amount of fluid is through some sort of supervised machine learning approach or model-based approach, where you would get a lot of information and data on patients and create a model out of it to predict where you would be from blood pressure standpoint. And then what you end up going to do is define the states, the variables that the algorithm needs to use, for example, blood pressure and so on. And out here, for example, I'm putting like 120, 60, 0 in this area here. And then in the step function, which is a transitional function, you'll say, given this is the states and the action selected, this is where you'd be. And then if the reward, which is, let's say, systolic blood pressure, if it was less than 90, you punish the algorithm by giving negative reward, or if it's the blood pressure map is appropriate, then it will get a positive reward. So that's definitely doable, but by already selecting a model to create that prediction, we added already a bias there. There's an error there, but it's kind of one of the challenges of reinforcement learning is by adding more complexity, you add more layers of error, unfortunately, and that's kind of for the old logic we say in to some degree in abductive reasoning is the easiest, the best kind of model to select is the simplest model usually. But the additional information you get in reinforcement learning in healthcare in this situation is you don't get that in supervised machine learning. For example, while you will understand in sepsis, for example, if you give fluid, this will predict as the map would be, but we don't know how much fluid you want to give, and you don't know how much pressure you want to give, and you can do it through a brute force approach where you simulate that patient and this setting and with a variety of fluid volume, for example. But that's very time consuming. You go back to the first slide where provided where the search space, especially for an infinite, not very discrete state, it can be very large in the search space. So in these situations, reinforcement learning will provide a very nice and fast search kind of algorithm to select the appropriate actions. And this is kind of another project we've been kind of attempting to work on for ICU management, and it's kind of going again about defining the problem. And here's the problem: maintaining the intracranial pressure low in patients with, have an elevated intracranial pressure. And so we can provide a lot of information about the patient, including their intracranial pressure and so on. And through adjusting some of the tools we use to control the blood pressure, including the amount of spinal fluid drainage, the amount of hypertonic solution we give, sedation, and so on, you can maintain that ICP at that specific rate in the way the algorithm will learn, basically as long as that ICP is less than 20, which we have some data suggest that, a better outcome with that range, then potentially we can automate that process without the cycle of nursing, manually checking the pressure, passing on to the provider who make the adjustments and the delay of these interventions. So definitely there are opportunities, I think, reinforcement learning, but we need, I think, to realize we're adding layers of abstraction here, including the model creation, so we can predict, so we can able to describe the environment, and then the algorithm itself to able to select the right appropriate sequence of action. And so I think it's a potential, I think, way to in the future to automate some of the routine tasks we do, especially here in the ICU and surgical ward. And there's that kind of the article I mentioned on management of sepsis using reinforcement learning by adjusting the fluid and the pressors. I mean, it's a very complex problem. I kind of went very briefly. I did not really talk about the subtypes, I guess you want to call it, of the solution of reinforcement learning, including policy and value-based. But I think every single video you can watch on YouTube, it's more, it kind of usually talks about how to better or more efficiently with less data solve a reinforcement learning problem. And I think less than talked about how to define the problem and the environment here in reinforcement learning. And I think, and especially in healthcare, I think that should be in the most amount of effort is better ways, better templates, like custom template and codes, and maybe even lectures on describing reinforcement learning topic in healthcare and how we can monitor even the results, because by itself is another challenge task. So I kind of I'll probably leave it at this, and I'll pass it back to you, Dr. Mather.
Yeah, thank you, Dr. Habboub. I think that was a great primer on reinforcement learning, and I hope we all get to benefit from that. And I think it's a very challenging space, trying to figure out what will be the best application of reinforcement learning in healthcare. But again, it's a great opportunity. So I'm gonna go to the questions, and I think there's a question over here from Dr. Guha, which is there a way to make sure no data points are missed from unstructured data like notes, which is like clinical notes? And then a follow-up, like, does Cleveland Clinic use any such tools to harvest the data? So Dr. Guha, I can tell you that you can't speak for Cleveland Clinic. It's a large organization. I'm sure people are using all different tools, which we may not be aware of, but I'm gonna have Dr. Cywinski take that question first. That is there a way to make sure no data points are missed from places like clinical notes? And in your experience, the methodology or the technique that you showed, was that a valuable tool or is that a valuable tool that could be applied for this purpose?
I don't think there is a straight answer to this question. I think you can use different tools. You can use natural language processing to sort of scavenge the information from the clinical notes, but you know, whether you're gonna miss something or not, you know, honestly, I don't know if there is any tool which will be full entirely foolproof.
Dr. Habboub, do you want to take that?
Yeah, I think the context is also important. For example, if you want to combine maybe text and some the more discrete data, or like a more structured data, it'll be the problem is, so let's say you have some sort of, let's say we want to predict the outcome of this patient given all their notes and then all the demographics and so on. And what I end up realizing soon, if you don't have enough data, the algorithm will never be able to utilize the text data, because the text data requires a ridiculous amount of data to be able to make anything out of it. Same with images, and then at the same time, there's much more valuable data, less noisy, I don't know if I want to call it that way, and the structured data. And if you combine both and train both at the same time, it's kind of completely ignore the text data and just use the other one, unless you have massive amount of data, and then that will be utilized. Now, text is available. I mean, I think our databases here in the clinic or other places, they will be able to provide text and home notes. But I think one of the challenges, and that's kind of the failures in the past here in other places, is also de-identification, and we're not able to de-identify it because sometimes there's some kind of hidden text in the notes that are difficult to figure out the name of the disease, or so the identification made utilizing text and healthcare data is very limited. Now, other more structured text in our notes, for example, operative reports or like anesthesia record, where they have a little better structure in that, and we can kind of still divide the text into more meaningful way. I think there's a lot of potentials, honestly, in from predicting like CPT coding, operative complications, and maybe even a hospital stay, and again, that should be readily available in Epic. The only downside, and I want to add, is more data does not mean better prediction, and it will likely be, unless if it's like assisted with the human, is more likely to be worse prediction because of more noise added to the data.
Yeah, I think that's a great point. Sometimes it just continues to reinforce the bias, because sometimes we find that the quality of data, especially in clinical notes, is not good, and it's just reinforcing either a bias that is carried forward or just adding too much noise in the system. But our team had published, working along with Spectrum, another company, our work on use of multiple sources of data, and that was the publication through the Proceedings for Machine Learning and Healthcare conference. And that is where we were trying to look at all aspects of data in electronic health record to predict ICD-10 diagnosis. So I think there's a lot of work that is being done in this space, and I think there is a lot more work that needs to be done in this space. And I think there is a lot of potential when you combine all the data together to make a meaningful infer some meaningful information through that. But I have a question for Dr. Habboub. Like, when you try to create the environment for this reinforcement learning, understanding how complex the interactions are in our day-to-day environment in healthcare, how do you capture all those interactions in that environment, or how do you create that environment that captures all those interactions that reside not just in the electronic health record space, but reside outside of monitored or EHR space?
Yeah, I mean, I think it's the real question in reinforcement learning, and not the actual reinforcement learning algorithms. How do you capture the right amount of data, and how do you model that, mathematically model that into an environment? So, for example, if you there's tons of, I've been actually looking for some time now, how do you model mathematically model things in general? So in drugs, that's very well utilized, modeling drugs and drug interaction with receptors and so on, and finance and so on. Much easier problem in physics and biology to model mathematically. Now, we don't have that opportunity, unfortunately, in healthcare, because it's very complex interaction, socially, from a social standpoint, from a clinical standpoint, provider, nurses, who knows. And you're limited at the end of the day. You're limited by whatever data you have in your EMR, or maybe some outside the EMR, from maybe videos, but again, like none of the data usually are not noisy. So you just end up with the whatever logical, whatever like a data engineering kind of perspective, where you say, okay, well, the best I can do is I'll take this X amount of data sources that seem like best quality data that should provide us some information. You apply some sort of abstraction here, the modeling, usually supervised machine learning approach, and then and that will basically, the model itself is the environment that basically. So utilizing supervised machine learning, I would say it will is probably the easiest way. Now you can create more a conditional environment where you say, in this situation use this, in this situation use that, or probabilistic approach, Bayesian. It can be on and on, but I don't know. The easiest way, I think, for somebody who doesn't want to spend weeks and months mathematically modeling things and testing, is probably using supervised machine learning.
Great. Dr. Cywinski.
I have one question for both of you, because the clinical notes, I think they are here to stay for quite some time, unless we figure something better how we communicate. So like, what do you think the future should be? How should we change the structure of the way we communicate, where we record our clinical observation in a way that they are more conducive to use, reinforced learning, machine learning, AI in the future, to make sense out of the data we capture in a clinical notes?
Dr. Habboub, do you want to answer that?
I think you're more expert than me on text, but probably, like, in the summary, I don't know. I think Watson in the past, where they talked about summarizing notes into more discrete, and automating a lot of the notes and leaving some areas for subjective and plans and so on. I think it's probably a better way, and I think, like, between looking at the comorbidities and similar notes in the past, you can generate much of our existing notes. And if you're able to do that, and somehow an easy way to verify that's correct, it will lessen this heterogeneity you described in healthcare. So I don't know if that would be reasonable or not.
No, I think that's a great point. I think we do have to somehow reduce that heterogeneity by automating some of the processes, so that the data that already exists is collected and is represented in a homogeneous manner into those clinical notes. So, for example, what we found in some of the work that we had done in the past was there might be a value of hemoglobin which corresponds to anemia, but one clinician might put in the diagnosis of anemia in the clinical notes, but another clinician may not put in that diagnosis, whereas the lab value for that diagnosis already exists. So I think taking a multimodal approach, just like the work we had done in the past, is one of the solutions to this problem. And the second solution that I see for this is moving away a little bit from what's necessarily there in the EHR transcribed by a clinician or a nurse or other healthcare workers. When I say that, I think if you think about all the other industries, the data that is collected is directly collected from the sensors and inputted into various different systems. So, for example, the pilot who's flying the aircraft is not sitting and manually charting all the different variables into some kind of an aircraft electronic record. And the sensors directly feed that data into the record, and that's where the black box and other instruments capture that. So till the time we don't start direct entry of data capture, and we're still depending upon human interface for that, I think those variabilities are likely to continue. And we need to move to a situation where there is direct input of that data and there is more homogeneity in what is being transcribed into the electronic health record. But I think that's a great question, Dr. Cywinski. Dr. Cywinski, my question was like the study that you did looking at this machine learning application, how generalizable or reproducible is it? Because that's one of the big challenges that we have seen, that yes, at a single center, you do a particular trial of a particular machine learning or AI tool, but then those results are hard to replicate at another institution. So in your expert opinion, what was your takeaway message from the use of this tool? How generalizable or reproducible is it?
So that's a great question, and actually that's the biggest problem. What I find with all the machine learning models, that they work, when you divide the cohort on a training and then testing population, but when you take it outside completely in a different environment, they perform quite poorly. So with this particular solution, and I'm not endorsing it by any means, I'm just saying general as a concept. I mean, the idea is that you apply to your own population and try to make sense out of the data, how it sort of aligns in a patient's or in an environment you're going to use it. So I don't think that idea here would be to develop some pathways, let's say, on our population and try to transplant it to the hospital 500 miles away, which may be dealing with different patients. I think the advantage of using this machine learning and this concept is that you can try to use it on your very own patient population, and as you use it, as you collect more data, you can get better in ability to predict the risk trajectories and sort of unearth the interventions which has the biggest impact on the outcomes.
That's great.
Dr. Cywinski, a question.
Sure.
Very interesting study, and one of the things I kind of challenged me in unsupervised learning is what are these groups mean, correct? And you were using your human logic and intuition to kind of reason with that. But sometimes you can cluster in 9 groups, or you can cluster in 5 groups, and how many clusters do you decide, and would that make sense, doesn't? How do you make sense of unsupervised learning in a more kind of a systematic way? How were you able to make sense of the results?
So in this particular project, just unsupervised learning just gave us an idea about how different is the population, and out of this, you're not necessarily going to make much sense unless you find some, this unsupervised learning clusters the patient along some outcome patterns. So that's the reason what we did. We look as unsupervised learning just to sort of get the glimpse on into how non-uniform is our population. But really, where the true discovery came along was with the supervised learning, where we look at the groups which had and the patients who had the most desirable outcome.
I think another aspect of this particular project was how quickly you could get processed information, because typically for a project like this, we are talking about months to have this kind of data analysis and meaningful information. So correct me if I am wrong, Dr. Cywinski, was that an important aspect of this project?
Yeah, that was one of the aspects what we try to prove, and essentially when you look at the cycle of whatever we do in a healthcare, the cycle between identifying the change you want to implement, implementing change, collecting data, analyzing data, and then coming up with change is extremely long, and that's very discouraging to all of us. And I think with this project, it was more of the proof of concept that once we establish which data we want to collect, it can be collected in near real time, and the process of identifying desired pathway, designing the interventions which are associated with the best outcomes can be done essentially on a fly, and it was pretty scalable project. So whether we look at 1,800 patients, but conceivably you can look at 50,000, 100,000 patients, and the output is exactly the same. That you can not only analyze the data and fine tune the intervention, but also you can provide real-time feedback to providers to get them to do what is required by certain pathway, and also by analyzing those groups and analyzing sort of inherited risk each patient represents, you can adjust the pathway to the individual patient's risk profile. I think that was the biggest sort of outcome of this study, just to prove the concept that you can actually analyze the data and make it meaningful to the providers in a near real time.
That's great. All right, we're going to close this event. I want to thank Dr. Cywinski and Dr. Dr.Habboub for great presentations and a rich discussion that followed. We'll be back with the March event. The date will be announced soon. Thank you very much for joining us, and great questions from our audience too.
Thank you so